Good morning. My name is Leanne Foster, and I am a provider outreach and education specialist here at WPS Health Solutions. And I'd like to welcome you to our Modifier Monday webinar on hospice modifiers, GW, GV, and condition code 7. Before we get started, I do have just a couple of housekeeping items for you this morning. We talked about audio. You do have that phone number and that access code in the chat. Training materials for today are available. They are available on our training center page, and I'm asking Mary to throw in the chat the link for that live events page. She's done so. Thank you, Mary. What you're looking for is today's event, and you'll see a link for training materials. And you'll be able to click on that, and what it'll download is the presentation that we're using for today. That's what it's available to you for presentations. We are recording the event today, so it will be available as an encore presentation on our live events page without the need to access YouTube. We do have a player on our website. We recognize not everybody's able to access YouTube for work because of security protocols that we all live with on a daily basis. So we do have that video available for 60 to 90 days on our live events page. After that, it will be available on our YouTube channel as long as the information is still valid and hasn't changed. If you have questions today, we are leveraging the chat feature for this, and as I indicated, Mary and Tom are monitoring that chat so that we don't miss any questions. Please throw your questions in the chat. I will be checking in for those questions. I also have some pre-submitted questions that I'll go through before I check in today. If for some reason we do have more questions than time allows, I will be creating a follow-up document that I will send out to all attendees so you won't miss any answers to any of those questions. And that document will include any of the questions that we were unable to answer during the live session. And before I get started, I do want to ensure that you have the best possible customer experience today. It is extremely important to myself, my team, and CMS that we provide you with the educational opportunities and give you the answers and the experience that you need. So you will have an opportunity after this survey a couple times throughout to tell CMS how we did. And I would really appreciate if you could take just a few minutes to fill out that survey. Tell me what you liked, tell me what we could do better. This is also an opportunity for you to provide feedback on educational events you'd like to see in the future. Your feedback really does drive our offerings. So again, please, I encourage you to take a few minutes to provide us some feedback on that. Thank you for that. That brings me to one more thing. I do have our disclaimer. So the material for today is accurate as of today. If you've worked with Medicare for any period of time, you know that Medicare changes often. So please make sure that you continue to monitor CMS communications, including the CMS website and our WPS GHA website for the most up-to-date CMS rules and regulations. As I answer questions, I will be using those regulations along with the information that's provided for that question. Also, CMS does prohibit any screenshotting or recording of this education. As I indicated, we are recording this, so you will have access to that recording should you want to see something again, have a question, something maybe you missed, or if you think this could be beneficial to somebody who was not able to attend today, you would be able to share that recording with them. So that brings me to our agenda for today. Today, the focus will be the appropriate use of the GW and GV modifiers along with condition code 7 for services that are provided by providers that are not employed by the hospice agency or services unrelated to the terminal illness. So what we're going to include today is a high-level overview of what's covered through the hospice benefit, how to determine if a beneficiary is in an active hospice benefit period, and when to use that GW, GV, or those modifiers or condition code 7. One thing I do need to point out to start is that it's important to note that only certain MACs process the claims for the hospice agencies providing the services related to the terminal condition. WPS does not process claims for the hospice agencies themselves. we process claims for the services that may be unrelated to the services provided by that agency. So what I have provided here, and there is a link in your resource section of the presentation today, I have included the map that shows the jurisdictions and the MACs that handle the claims for the hospice agencies. So I'm going to start with hospice election. Medicare covers services that are provided by hospice agencies for a terminal condition if a beneficiary elects the hospice benefit. It's not automatic. It has to be elected, and we'll talk about that election in a few minutes. When a beneficiary elects the hospice benefit, it is going to restrict payment for professional services. By electing hospice, the patient is waiving their rights to standard Medicare coverage for treatment and management of the terminal condition. Their services must be, these services, so if they're related to that terminal condition, must be provided or arranged by a Medicare certified hospice to be covered under this provision. When a patient has a terminal condition, that is going to be certified by a physician, and that condition has a life expectancy of 6 months or less. The patient at that point can elect the hospice benefit, but again, it's not automatic. They do have to elect that. They'll elect it by submitting a notice of election, and that notice of election must be submitted to the appropriate Medicare contractor within 5 calendar days of the election. So there's a little bit of a period time. It is submitted by the hospice agency, and it will cause the beneficiary's eligibility to be updated, showing that they are in a hospice period. And we'll talk about checking that eligibility today as well, because that is one of the things that causes a lot of claims denials, is just not knowing that the beneficiary is in that hospice eligibility, that hospice period. So that eligibility, though, does need to be in place before hospice services can be billed. The notice of election is, as I said, is submitted by the hospice agency. Each hospice agency is going to have their own notice of election. CMS does not have a designated form for this, so it's something that is created by the hospice. There's not a standardization for it. It does need to include some things. It needs to identify the hospice agency that will be providing or arranging all of the services related to the patient's terminal condition. It has to have an acknowledgement from the beneficiary or the representative that they have a full understanding of the fact that hospice care is palliative and not curative, okay? We're keeping them comfortable, and that they are waiving Medicare coverage for certain services. It's going to also need to include the effective date of the hospice election, because that's going to be critical to claims and whether it's payable, not payable, is it part of that hospice? We're going to look at that for overlap. It next also has to identify the attending physician. Now that attending physician is chosen by the beneficiary or the representative, and we're going to talk about that a little bit more in just a few minutes. And then it has to have a disclosure of disclosure information. It's going to be outlined in the Medicare policy manual, which we're including a link for, but it has to include information on cost sharing, and that it also has to outline their right to receive an election statement addendum for any services or items the hospice determines to be unrelated to the terminal condition and not covered by hospice. And then finally, that notice of election, also referred to as an NOE, does need to be signed by the beneficiary or the representative to be considered valid. There's more information available on this. We're certainly not going into every level of detail on the notice of election, but there's more information available in the Medicare Benefit Policy Manual and in Chapter 9. And as I mentioned, I have included a link to that in your resource section today so that you have that if you'd like to take a look at that. So hospice eligibility. As I mentioned moments ago, the most common denials that we see are due to billing for services that overlap with hospice eligibility. One thing that can happen is that eligibility is not going to change until that notice of election has been processed and is in place. So this is something that may not be there immediately on the day that they elect hospice, and it's something to be aware of. So you do need to be vigilant about coming out and checking for hospice. This can be checked in our secure portal, and it's going to help you know when that service needs to be billed by the hospice because it was performed by the hospice or under arrangement with the hospice, or if it can be billed to Medicare with the appropriate modifier, which would be the modifiers we're talking about today. Like I said, the most important thing you can do is check for that eligibility. And this is a screenshot now. This did just change. Yesterday, we did implement some changes to our portal. So when you go into our portal, it's going to look a little bit different, but I'm going to show you that manual so you can see that it is not that dissimilar. But here you'll see in the red box that there is a section under eligibility for hospice, and it's going to show you that who the hospice provider is, the start date, if they've chosen to revoke their hospice period, which a beneficiary can, what that date would be, but it's going to show you the information that you need to know how to bill for a service or know if you're overlapping a hospice period. So I'm going to go out to our website and show you where you can find that manual. So I'm on our WPS-GHA website. And at the top, this user login and password is our secure portal. And underneath the login button is the portal user manual. And here you will see all of the transactions that you can execute inside of our portal. And I'm going to scroll down because I will get to eligibility check under claim transactions and searches. And here it's going to talk you through where eligibility is coming from, but it's also going to give you step-by-step, providing the information and screenshots of the information that you need in order to check that eligibility. And in this screenshot that's provided in the manual, you will see hospice. It's here on the second line. It's the fourth box in. It's grayed out. And that's just because that's maybe not, it's not active. There's not hospice information for that patient at this time. It will activate when there is, but it is in that eligibility check. And again, that is generally one of the biggest reasons we see denials is that we're overlapping and that we're not checking eligibility. So this piece will be critical to ensuring that we minimize claim denials for you. So during a hospital election period, Medicare will cover services that are provided by the hospice agency or arranged by the hospice agency. These services are going to include things such as nursing care, pain and symptom management, mental health services, and any other services that are specified in the plan of care. That's going to be part of that. Remember, the patient is waiving the rights to standard Medicare coverage for treatment and management of the terminal condition. So it's going to be more about, again, that palliative care, not curative care. Now, Medicare, as I said, will cover services provided through some sort of arrangement or contract with that hospice agency, and they will cover services that are unrelated to the terminal condition. Services that are made under arrangement, though, will not be billed to Medicare. They will be billed to the hospice and submitted as part of the hospice claims. The unrelated to the terminal condition, those are going to be the codes that you're going to see billed to Medicare with one of those modifiers, depending on the scenario. And we'll talk through that. If the provider is performing the contracted or arranged services not employed by the and is not employed by the hospice, and this can happen with an attending physician, and we'll talk about that in a minute. But generally speaking, as I said, they're going to need to work with a hospice for reimbursement. This is something we do see where providers will bill us directly. So as I said, you do need to bill the hospice, and the hospice will bill for those services. So let me start with direct hospice services. So direct hospice services are services that are, again, provided by the hospice agency or provided under arrangement. Under arrangement, again, means the hospice has made the arrangement for the service, and this is a service that perhaps the hospice doesn't have the staff or the facilities or the equipment to provide, okay? But the provider and the hospice agency have an agreement for the payment. They are going to, again, submit their bills to the hospice agency. Hospice is going to bill. When they get reimbursed, the hospice is going to pay the provider that provided the service under arrangement. If those services are billed directly to Medicare and they were made under arrangement of hospice, they will be denied if they're billed directly to Medicare. And again, you'll be directed back to that hospice. Next, we're going to talk about attending physician services. So the attending physician is identified by the beneficiary or their representative at the time they elect the hospice benefit. That attending physician will have the most significant role in determining the delivery of the patient's care related to the terminal condition. And one question that came in as a pre-submitted question was if they could have multiple attending physicians. They will designate one attending physician. And it has to be identified on that notice of election. It's not something that notice of election is not going to be processed completely and fully without that information on there. So the attending physician services can be provided by a physician, a nurse practitioner, or a physician assistant. However, again, it does need to be indicated on that notice of election with enough detail so it is clear who the designated attending physician will be for that patient during that hospice benefit period. If the attending physician is employed by the hospice agency, and they may not always be, if they are, claims are going to be submitted to Part A as part of the hospice claim. The beneficiary does have the right to designate an independent attending physician that is not employed by the hospice. Perhaps it's their family physician, perhaps it's their oncologist, but they don't necessarily have to appoint an attending physician that is employed by that hospice. So as long as they're providing services that are reasonable and necessary for the treatment and management of the terminal condition, that is the key piece of that. When the attending physician is independent, though, the hospice they're not going to bill as part of that hospice claim. The hospice is not being reimbursed for that piece. They are going to be eligible for reimbursement through Medicare Part B. And in this case, they will bill the appropriate MAC, and we start using the modifiers. The modifiers that you would use here is going to be the GV modifier to indicate that they are not employed by the hospice agency. So again, when you have an attending physician who is not employed by the hospice, they are going to bill directly, not part of the hospice claim, because they're not part of that hospice agency, and this doesn't fall in the same category as being made under arrangement. So they're going to bill their services with the GV modifier. One of the pre-submitted questions that came in was, what if the physician isn't their designated attending, yet sees the patient for something, and this is something that might be related to the hospice diagnosis. The example that was given was the patient's presenting to the ER for new back pain, only to find out that it was caused by the terminal condition. So the answer to that is they would need to work with the hospice for payment since the condition was related to the terminal condition. They're not going to know that when they present to the ER, but they are going to need to go back to the hospice to work through that and bill the hospice for that. So I mentioned the GV modifier, so we're just going to talk about that a little bit more with the attending physicians. So if the attending physician, again, is not employed by the hospice, they can bill Medicare Part B, but again, are going to need to use that GV modifier because they are not billed by the hospice because the attending is not employed by the hospice. So the GV identifies a service provided by an attending physician not employed by the hospice. So for example, physicians, nurse practitioners, physician assistants that are providing care or coordinating care related to the illness that are not employed by that hospice, and they're not receiving reimbursement from the hospice are going to need that GV modifier. I do need to stress, though, that if the attending physician is being paid as part of the hospice claim to Part A, or under some type of an agreement or contract with that hospice, they should not bill Medicare Part B services for the services related to that terminal condition. They're not going to bill both. They're going to bill one or the other. This is also true if that attending physician is employed by the hospice. So if they're employed by the hospice, they're getting paid by the hospice, they're not going to bill directly for their attending physician services. Now that GV modifier is also used for professional services only, and any ancillary services such as labs, x-rays, injections, those would need to be billed through the hospice. So this is just the attending physician's professional services that would use that GV modifier. Pardon me. Tickle in my throat, my apologies. So next I want to talk about unrelated services. So there are going to be situations where the patient may receive services unrelated to the terminal condition. Let's say that the patient is in hospice for cancer, they fell, they broke their arm. We're certainly going to treat for that broken arm, and that's going to be unrelated to that terminal condition. That would be an example of an unrelated service. So eligibility is going to be determined by the diagnosis on the claim and the diagnosis of that terminal condition. We're also going to be looking at the modifiers that are being used. So for unrelated services, there's two options here. There's the GW modifier. So that is going to be for those professional services that are unrelated to the terminal condition. And then for an institutional claim, it's going to be condition code 07. Now, if the entire claim on a UB04 or 837I is unrelated, you can use that condition code 07. If you're billing a little bit of both, then you're going to have to use that GW modifier on the lines. So it just depends on how that claim is coming in. And with all of this, you will need to ensure that your documentation supports unrelated to the terminal condition. So with that, I am going to go to our pre-submitted questions that I had, and then I will check in with Mary for any questions that may be in the chat. So the first question was use of the GV at GW when Medicare patient who are enrolled in Medicare managed care plan enrolls or disenrolls from hospice during the month. These plans do not pay anything for the entire month when this happens. Are these modifiers allowed in the scenario for billing to the, or excuse me, in the scenario allowed to bill for Medicare directly? So as long as you are billing traditional fee-for-service Medicare, you are going to use the modifiers. From a Medicare Advantage plan, I can't speak to whether or not they are allowing you to use those modifiers. You need to check with that Medicare Advantage plan to determine if they're recognizing those modifiers and how to bill for that. But those modifiers are used when you're billing to traditional Medicare. The next question that I received was, should we add GW or GV before the claim goes out or wait for that claim denial? It's a good question. You absolutely want to apply those modifiers when submitting the claim and not wait until the denial is received. That's going to eliminate unnecessary work for you, unnecessary appeals being submitted. Again, it's going to come down to checking that eligibility to make sure that you know which modifier, if you need to use one of those modifiers. But certainly if you know which modifier applies, don't submit the claim for denial first and then apply the modifier and appeal. Submit the modifier right away. Next question was, when billing for outpatient dialysis services and hospice on the same day, is the need for condition code 07 determined by either the patient's primary terminal diagnosis for electing hospice, and if the outpatient service is due to the same diagnosis code, or if the hospice indicates the diagnosis code for outpatient services is or is not related to the terminal primary diagnosis code for electing hospice. So what we're looking for is the diagnosis code on the claim, the terminal diagnosis, and the use of the modifiers or condition code. Again, documentation does need to support that. So it's case by case, but we are looking at both the incoming diagnosis, the terminal diagnosis, and the use of those modifiers and condition codes. Next question that we have, when is the hospice responsible to pay for dialysis treatment on the same day as hospice enrollment? So if the patient is in hospice, what are they in hospice for? So we're looking at that diagnosis to make that decision. It's not a one size fits all. So it's going to be a case by case basis. Unfortunately, I don't have just one simple answer to that question, but you have to look at what that terminal condition is to make that decision. The next question that I have is, what type of information does a provider have to obtain to bill the GW modifier indicating the treatment is unrelated to the hospice? This is again going to come back to that documentation. That documentation does need to support that the service is not related to the terminal condition, and of course they are going to apply that modifier. It all comes down to that documentation. Got a couple of more pre-submitted questions, and I'll check in with Mary. On the discharge from general inpatient to inpatient hospice, do you use GV or GW? Patient will stay in the same facility that they're being discharged from, but they're being discharged from general inpatient to hospice care. So you're going to have to look at the hospice benefit period, or the hospice effective date. So you will bill Medicare for the inpatient stay for the time period before the hospice election, and the discharge would be the effective date of election. Then you'll bill the hospice for the services after the hospice election date. The two should not overlap, and again, cannot stress enough, you have to check the Secure portal. And again, I understand this is something where that might not be instantaneously available, but we really do need to be looking at that. And last pre-submitted question, I'll check in with Mary. When the hospice denies as not approved or authorized by them for a service, is it appropriate to bill Medicare with a GW or GV modifier, or does this become patient responsibility? So it comes down to if the service is related to the terminal condition. If it is, they are going to need to work with the hospice, and sometimes that might take multiple conversations. So if it is related to the terminal condition, that needs to be billed to the hospice. They can only bill with that GW if the service is unrelated to the terminal condition. And unfortunately, we're not involved in those conversations between regarding the services that are made under arrangement. That's between the provider and the hospice. All right, with that, that brings me to the end of our pre-submitted question. Mary, do you have any questions in the chat?
We do have some questions, Leanne, and I think some of them might overlap a little bit with things that you've already talked about, but I'm going to go ahead and read them to you. Who would be responsible for the charges when a patient is inpatient at a SNF, skilled nursing facility, and they are on hospice? The skilled nursing facility sends the patient to the emergency department for a reason related to the hospice. The patient has altered mental status. The patient did not ask to come to the ED, and the hospice was not aware that the patient was being sent to the ED.
So there are a couple of things happening there. If it's related to the terminal condition, they're going to have to bill the hospice and work with the hospice for that, and that can happen with emergency room visits. It's not necessarily prearranged. It does have to be medically necessary, but that is something they are going to have to work with that hospice if it is related to the terminal condition.
All right, here's another question. Can you clarify billing procedures for a patient who enters hospice with a primary diagnosis of terminal diagnosis, that is, of ESRD, end-stage renal disease, and dialyzes on the day of hospice admission? This learner would like to understand the responsible payer when the patient dialyzes early in the day and then chooses hospice later in the day.
That's an interesting one because the hospice eligibility doesn't have a time. So that's going to depend on, it looks like it is part of a primary DX based on what's being provided, on the terminal DX, based off of what is given in the chat. And that is something they would need to work with the hospice. Tom, did you have any other insight on that particular one?
Yeah, so just to clarify on this one, and I just want to make it very clear, the time of day absolutely matters. The problem is not that, or the system has a limitation in place, and the limitation doesn't say election at 10 o'clock or election at 2 o'clock or anything like that. So from what I'm gathering, and Mary, again, if you could read me back to make sure that I'm getting this right, but read me back that it was at a dialysis in the morning, time of admission in the afternoon, or time of admission later the day. Is that what I understood? Can you
Yes. Yeah.
Okay, yeah. So here's what's going to happen with this one. Because you cannot bill the hospice for any service before admission. However, our system isn't smart enough to know that it was before admission. You need to indicate to us that it was before admission. Now, this is a workaround. It's not like people don't say, oh, it's not coded correctly, or it's not. It is coded correctly because it's a workaround and we have no other way of doing it. You would have to build the appropriate condition code if you're billing on a UB or the GW, depending. So when we look at that, we do need that in. Now, this one, otherwise, depending on the time of admission, if they were admitted and then did dialysis, then that is hospice related. So hopefully all of that kind of mixed together. Really check the time, verify the time. Then remember, it's a system workaround because the system's not smart enough to have that time in place. There's no field for it. There's nothing that tells us when the admission was actually done, and that's going to be your issue here. So hopefully that clarifies it. Again, if you have more questions, put that back in and we'll talk about that one again.
Thank you, Tom. And Mary, next question, please.
All right. If the service is during the month of the hospice election or ending of hospice election, the Medicare managed care plans deny and tell us what we have, or tell us that we have to bill Medicare. Is that correct, or should they be paying if hospice has ended or not started?
So Medicare is going to pay during that hospice election. I cannot speak to whether or not the Advantage plans are doing that correctly or not. That's going to vary based on plan. But Medicare will pay for the hospice election. You need to work with your Advantage plan to determine their policies on that.
Okay, thanks for that great reminder. If a patient elects hospice during a palliative care provider inpatient visit, should the palliative care provider use GV or GW modifier?
Tom, I'm going to ask for your assistance on that one.
Sure. So again, we're gonna jump right back to this time of day thing. Yes, they've elected it. Did the palliative care provider, one, are they named as the the supervising over the hospice, the tending? Thank you. That's the word I couldn't think of. That's the only time GV can use. So I want to make that very clear. They could not necessarily use GV. They might be able to use GW depending. Now, depending on when the admission was done and were they at the location, because according to the hospice manuals and according to how Medicare pays hospice, you have to be at the location in which the hospice is going to occur for the admission to occur. So it really this one is very hard to answer because there's so many moving components to it. So I don't want to give you a wrong answer, but what I would like you to do is, if you still have questions, if you still want some more information, send that into us. Leanne will work with myself and Mary, and we'll get you the best possible answer based on some different scenarios and things like that. So this one's going to be just, there's too many moving components to be able to answer it real effectively without some more information.
Thanks, Tom. Here's the next question. Leanne, would you please address, if you are able to do so, rural health billing when the designated attending physician is employed by the RHC and not the hospice? Claims are submitted on an institutional claim form.
Okay, so in that case, that attending is going to be employed by the RHC and not the hospice. So then they would be able to use that GV modifier for their services. Because again, the attending services will be billed to the hospice and included as part of that hospice claim when they are employed by that hospice.
Thanks. Here's the next question. When providing therapy services to a beneficiary in a skilled nursing facility that has an active hospice election, who should be making the determination if the services are related to the terminal condition?
So that would be part of the attending physician's role in that plan of care. They are going to have that oversight and make the determination of what that plan of care is and whether or not they are related to that. Of course, documentation is going to have to support all of that.
Great. When a patient is seen in a specialist office for unrelated hospital medical conditions, an example would be if the patient had a fall and fractured the hand, and the specialist, not being aware the patient was under hospice at the time and billed the claim as normal, then a denial is received indicating the patient is enrolled in hospice. Would the specialist then just bill with the GW modifier? Is there any additional information required, like an election statement addendum?
So based on the information provided, the specialist is seeing them for that fracture that is not related to the terminal condition. So you're correct. They would be able to use that GW modifier because it's unrelated. Again, documentation has to support that, but based on what's being described, it's unrelated. GW modifier applies.
All right, back to the Advantage plans. The learner states that Advantage plans state that Medicare always has to be billed and that they do not pay for anything during the months of hospice. She's asking if the rules changed that now direct the Advantage plans to pay under hospice, but visits not related to hospice.
So the hospice services are going to be billed on a monthly basis, which is probably what you're running into. But again, I can't speak to what the Medicare Advantage plans are paying. They're all going to be a little bit different. Tom, did you have anything additional on that?
I would give you, and I'm going to put a link in the chat. I want you guys to take a look at this. Look at this link. Now, this is the Medicare Managed Care Manual. This manual is actually something that is given by CMS to the managed care plans. Inside this manual, it's going to have section 10.4. Now, this is the hospice coverage section. And inside there, it's going to give you the general information. Now, I do want to make it clear that when we're looking at this manual, again, Leanne, myself, Mary, we can't really talk about it. What I can do, though, is give you this manual, give you this section. The reason that I'm doing this is because it's how we'll be handling it. Now, someone said to me, hey, I get that this is how they should be handling it. What else do I need to be aware of? Okay, first, not all managed care plans are equal. So if you have a certain type of managed care plan, they may have different rules depending on what happens with that managed care plan. So there was a test is in 2024, it will end in 2025, which makes the managed care plan responsible for it. So you want to take a look at that. So there's a lot of moving components into this, which is why they may or may not be saying it. But again, check out that section. It's called the Medicare Managed Care Manual. It's chapter 4. It's their benefits and beneficiary protections. And you want to check out 10.4, which is all about the hospice coverage and when they're supposed to pay and when they're not. There's actually a nice chart in there that'll tell you they should pay or they should not. I'm just pretty familiar with that as I have to deal with it for ambulance a lot. That's a question that comes in a lot for ambulance. So that's probably why Leanne wasn't as familiar as I am with that one. Go ahead. Sorry, Mary.
Thank you, Tom.
Thanks, Tom. Here's another question, Leanne. Can you please clarify on page 6, Home Health and Hospice MACs? The map shows 4 MACs. Are these the only MACs that process institutional claims with the GV modifier?
So those are going to be the MACs that process the claims for the hospice agencies themselves. So for actual hospice services and services provided by the attending physicians that are employed by the hospice. The attendings that are not employed by the hospice are going to be able to bill Medicare Part B for their professional services, and that would be us, WPS would process those claims for our jurisdictions with that GV modifier. Thank you for that question.
Thanks, Leanne. That's it for the questions in our chat feature.
All right, thank you, Mary. Thank you, Tom. As I mentioned, I did include some resources that we talked about today. I have included an article on billing services during a hospice selection that's available on our website, along with our portal user manual, so that you have that available to you quickly. And then I've also included some of the CMS resources that we talked about today, including the jurisdiction map, but also a medical learning network article that includes a lot of links to the benefit manuals and some of the other information that we were referencing today. I've also included links to the claims processing manual and the Medicare benefit policy manual, so you have those. And I'm going to check in one more time. Mary, did any questions come in?
Hey, Leon, I'm not seeing Mary come off of mute, but they did have a question
sorry.
related, and it says, if hospice isn't aware a patient was seen to the ED by the SNF, are they still responsible? So in other words, sent to ED, condition related, hospice unaware, so they just want clarification. Are they still responsible to hospice, responsible for those ED charges because it was a related condition?
They're going to need to work with that hospice because it's a related question that does need to be billed through that hospice claim.
Right, and that is it for the questions again, Leanne.
All right, thank you. So in a few minutes, we're going to wrap up, and in a few minutes, you're going to receive an email that is going to thank you for attending. So don't delete that. If you're attending for continuing education credits, this is going to be your certificate of achievement, and it is going to contain, you'll see that in the red circle on your slide, is going to contain the date and the contact hours that can be submitted to your certification or accreditation body for those continuing education credits. It's also going to include a link to our survey for you to provide feedback to us. Now, if you didn't get that, a couple things happened. One could have gone to your junk or your spam folders. That does happen, depending on your security settings. The other thing is that if you attended today by phone for audio, our system simply can't auto-generate this email to you. In both scenarios, doesn't mean you're out of luck. If you need that and did not receive that, email us. You're going to get that email box again, but it's the wps.gha.education@wpsic.com mailbox. And just let me know you need that certificate, put the title of today's session, and if you attended by phone, please include your phone number. In either case, once I confirm your attendance, I can create a certificate and get that out to you. I will also be taking follow-up questions for 7 days following today's session. Again, sending it to that WPS GHA education mailbox, title of today's session, just so that the individuals monitoring that know, hey, this is a question for Leanne, and I'll go ahead and get those responses out to you. Just want to be clear, though, that anything that is claims specific, something that's in processing, that still has those claims questions still have to go to customer service. I don't have access to the claims system that would be needed to answer those questions. As I mentioned earlier, your feedback, super important to us. So you are going to receive a link. There's a couple of ways. One, you're getting the link in the chat. The other is when you leave this session, there's going to be a pop-up. That's not spam. That's not malicious. That's just a redirect telling you you're leaving our webinar software and going into the CMS survey software. And again, that feedback is super important to us. Tell us what you liked. Tell us what we could have done better. And again, this is your opportunity to provide feedback. I'm hoping you guys got answers to your questions today and hope you had a great customer experience today, and I'd like to hear that feedback. With that, that does conclude our session today. On behalf of Mary, Tom, myself, and the entire WPS Health Solutions Provider Outreach and Education team, I'd like to thank you all very much for taking time out of your busy schedules to attend today. We recognize everybody has a lot going on, and carving out this time can be a challenge. So thank you very much for taking that. Again, we look forward to your survey comments and any topics that you'd like to see in the future. With that, I'd like to thank you. Hope you all continue to be well. Have a great day. You may now disconnect.